Right. So I've got Cat Monkhouse with me here today, and Cat is a women's health physio who practices, has a treatment room up in East Kilbride, which is very close to where I also practice. So I asked Cat to come into the group today, really to talk about all things pelvic health related post C-section. Well, Kat, would you like to introduce yourself first of all?
Yes, I will. Thanks, Sam. So yeah, as Sam said, thank you for the introduction. I'm Kat. I am a women's health physio. So I came into women's health, as many of us do. I'd started out in musculoskeletal physiotherapy. That was kind of my speciality. Had my first son 7 years ago, and very quickly realized that even as a musculoskeletal physio, I was not prepared for the changes in my body during pregnancy and the changes in post-childbirth. Did a lot of things wrong, in the sense that went back to running too early, thought, oh, I'm invincible. I'm 28, I can go back to all these things, and just didn't really have the knowledge about pelvic health. So within a year or so of him being born, I realized that this was the area that I really wanted to specialize in, and I started doing numerous courses and learning and diving deep into the pelvic health world. And it's really where my passion lies, is in supporting other women, whether they're pregnant, postnatal, menopause, perimenopause, just helping other women live their best life, live well, remain active. And yeah, that's what I want to be doing. So that's what I'm doing now.
Fantastic. So let's start off with the really obvious question, because I get this all the time from my clients.
Yeah.
In my general kind of postnatal chat, I'm always like, so how's the pelvic floor doing? And if a client has had a C-section, I'll quite often hear, oh, I think it's fine, but I don't need to worry about my pelvic floor, surely. I had a C-section. So tell us why that is not the case.
Yeah, so I hear exactly the same thing all the time. People think, I didn't deliver, so I didn't have that pressure and the whole delivery experience. So in one thing it does protect you from is birth injuries. So it protects you from instrumental birth injuries using forceps or ventouse, and it protects you from the tears, which is what I think a lot of people are scared of when they go into childbirth. They're quite worried about the tearing. So it is, yeah, you have a different area where you've got a scar, but it's a different situation. So it avoids that. However, on the flip side, what we do know is that the biggest stress in the pelvic floor, or most of the stress, is the pregnancy, because you're going for 9 months, your uterus is growing with baby growing, and all of that pressure on your pelvic floor throughout that 9 months has an impact. So it can weaken the pelvic floor. We know that baby pushes on the bladder and changes the position of the bladder neck, which means that stress urinary incontinence and urinary frequency go up during pregnancy. And we know from the literature.
Can I interrupt there? Can you tell us what stress urinary incontinence and urinary frequency is?
Of course, sorry, I'm doing the classic video thing of assuming people know what these terms are when actually they might not. So apologies for that. So stress urinary incontinence is the classic one that we often see postnatally, regardless of mode of delivery, which is you cough, you laugh, you sneeze, you leak a little bit of urine, or people will say they want to return to, say, running, and they'll get a bit of leakage with high impact. So skipping is one if they go to like a CrossFit style gym, or jumping on the trampoline with their children. These are the type of things that can cause stress urinary incontinence. Urinary frequency just means going to the toilet a lot more often. So that is one of the classic pregnancy symptoms, which most of us probably experienced in pregnancy, partly to do with hormone changes, and also partly to do with that the uterus putting some pressure on the bladder as baby grows and changing the angle of the bladder neck as well. So it's linked to that. There's just not a lot of room in that bladder anymore for babies growing and taking up a lot of the room. We also know that during pregnancy, progesterone and estrogen continue to increase throughout, and they peak at about 32 weeks. So constipation is quite common because your progesterone levels are quite high. So if you're constipated and you strain, that has a terrible effect on the pelvic. It's not a good thing for the pelvic floor. Basically, with the pelvic floor, what we want to avoid is pressure, like downward pressure on the pelvic floor. So straining with constipation, and of course the weight of baby is a huge downward pressure on the pelvic floor. And from literature and from research, looking at some studies that have studied like up to 4,000 women, one of them 200, another one that I can think of off the top of my head, they have shown that there's other things that indicate if you're likely to have leakage post-pregnancy. It's not mode of delivery that had the strongest correlation. One of them was if you had a continuous cough in pregnancy. So again, that links back into that pressure down when you cough, you get that pushing down on the pelvic floor. That led to you being 4 times more likely to have have some sort of urinary incontinence postnatally. There's also a sort of genetic predisposition as well. We think that's to do with the type of collagen in your body, one of the connective tissues in your body. So if your mum had issues with her pelvic floor, regardless of how you deliver, you may go on to develop issues with your pelvic floor as well. That had quite a strong correlation. And one of the strongest indicators was if you actually had stress urinary incontinence during your pregnancy, that laugh, cough or sneeze, a little bit of leakage, you're much more likely then to develop that or continue to have that problem post-delivery. So that was some of the things that were linked, not so much mode of delivery. So that's why it's not the case. It's a myth that if baby is a cesarean delivery, you don't have to worry about your pelvic floor. You still need to keep doing the exercises. Don't stop just because babies come out the cesarean section route rather than a vaginal delivery route.
Okay, so if you had no issues during pregnancy, why should you start thinking about your pelvic floor postnatally?
Okay, so the other time in our lives where we have pelvic floor issues starting to occur is usually around perimenopause or menopause. So perimenopause, you can technically say sort of start being concerned from 35 onwards. 40, definitely start thinking towards planning for the future and building in good lifestyle habits now in preparation for those living well post-menopause. At menopause, we have huge changes in hormones again. So again, it's all back to these hormones. They change at pregnancy and they change again at menopause. So in menopause, we have huge drops in our estrogen levels. And our estrogen is really important for maintaining sort of the tone and the lubrication and everything of the vaginal tissues and keeping the vaginal tissues nice and toned, and also testosterone drops, and that also has an impact on that. So when all of these hormones start to drop, we then can have issues again with urinary problems like incontinence issues coming back at the menopause. So it's really important that you don't just think, that's why it's good to get into the habit of doing your pelvic floor exercises like once a day is fine. If you're not having leakage or any sort of problems, any heaviness, any dragging, any bulgy feelings in the vagina, difficulty inserting tampons, nothing like that. If you're fine, no issues, you can run, you can jump on the trampoline with your kids, I would still say to people, do them when you brush your teeth like once a day as a preventative, like to help you preparing for that next phase of life at menopause. Does that make sense, Sam? Yeah.
Yeah, absolutely. Yeah. And I think it's human nature to be reactive instead of proactive.
Yeah.
So because there's so many things that we can be proactive about.
Mm-hmm.
So if it's one of these things, if your pelvic floor is doing okay, then it tends to go by the wayside. But it's trying to get these good habits in place.
Yeah.
Which will stand us in good stead for the long term.
Definitely. And it's not, I was going to say as well, it's not even necessarily just isolated exercises. So if we know the glutes and the pelvic floor muscles innervate by the same nerves. So if you strengthen up your glutes and if you do like maybe if you're doing squats, there's good evidence base for squats, lunges, your sort of resisted rotation of the hips. So like maybe your clams, that kind of exercise, step ups, all of these exercises have a really good involuntary contraction of the pelvic floor, which we want as well. We don't want to always have to be consciously thinking from a top down sort of way, like brain engaged pelvic floor. Our pelvic floor should also function on a sort of automatic level as well. So things like your squats and lunges and things, all of those exercises, stepping up onto a box, using lots of glute, all of those exercises are really, really good. Even running actually has been shown to create, I think there was a study recently, and don't quote me 100% on this, but it said in the study that running, you had 100 times more activity in your pelvic floor than you would have doing a sort of independent voluntary Kegel, your voluntary max contraction. So you consciously doing one Kegel versus your running, the running gave you 100 times more activation. So other exercise is really important as well. It's not just about those Kegels, it's about, and for bone health, heart health, brain health, everything. But we're also working on our pelvic health when we're exercising. So it's got multiple effects. So yeah, I've possibly gone off on a tangent there, but hopefully it links in and kind of makes sense.
Yeah, no, absolutely. And I think, you know, there's, if we want to make our arms stronger, well, we could do bicep curls, but we could also just use our arms more.
Yeah, totally. And that's, I wanted to highlight that because I think I kind of do tend to say to people, like some physios, there's a big Kegel or not Kegel debate. I think doing the magic brush your teeth is really, really good. It's a good way, it's a good habit to get into. It's maintaining that pelvic health rather than being reactive, as you said. But I think also it's being aware that doing the other exercises as well and being active in general, and like you said, doing, just using the body and moving is also beneficial for the pelvic floor. And I think sometimes people can be scared as well to go back to things that they enjoyed. And of course, seek help, see a physio near you, a women's health physio near you. If you have got any pelvic floor issues, or come to me if you're local to here, and we'll help you. But part of what we want to do is help you to not be scared to move again. You know, don't let pelvic health issues stop you from moving. And I think that's one of the biggest things that is important to get across, that, you know, these issues can be helped, they can be improved, and we can help you to move again. So yeah, don't be scared to get help if you need it. And if you are fine, things like running and jumping, if you've got a healthy, well-functioning pelvic floor, it's actually helpful. So yeah.
So can you talk through some of the other issues that are commonly associated with pelvic health? So obviously we mentioned incontinence.
Yeah, so I think it's important to highlight, you get urinary incontinence, which is your pee, obviously, like, you know, if you've got a bit of leakage from the front. Anal incontinence is also very, very common. So 1 in 5 women over 40 have some degree of anal incontinence. Now, there's a spectrum of anal incontinence. So it can be leakage of wind. So inability to control the passage of wind would be considered anal incontinence within those statistics. But that's actually quite common postnatally or at menopause. So that's something that people might not realize, you know, is within this issue, that you can still get help with that. And if you improve your tone and your coordination of your pelvic floor, that can reduce. It's not something you just have to live with. And obviously that spectrum can go right through to sort of being unable to control stools. So other things would be pelvic organ prolapse, which is very common, again, postnatally, or in general. I think it's 1 in 3 women have some degree of pelvic organ prolapse. We think potentially up to 1 in 2. Now, pelvic organ prolapse is, I'll explain a little bit what that is. The symptoms of it would be usually like a heaviness or sort of dragging sensation within the vagina. And a feeling of sort of a bulge in the vagina. You might feel like you can't put a tampon in, you're unable to insert a tampon, it doesn't want to stay in place. And what that means is, it basically means, I need one of your lovely diagrams here, Sam, I think. But I didn't ask you to draw one, so you've not got one. But Sam does the best diagrams ever. I'm not artistic, unlike you, so I'll just explain. So basically you've got your vagina in the middle, and then your bladder in front, and your rectum at the back, where obviously the stool passes through. Now, what you can have is, you can either have a prolapse from the anterior wall, the bladder wall, sort of presses into the vagina a little bit, okay? Or the same thing can happen with the rectum, that can cave in a little bit into the vagina, the bladder wall can cave in a little bit, or the uterus sitting on top can descend a little bit from where it's meant to be. And these are all considered 3 types of pelvic organ prolapse. Now, I think that sounds quite scary. And when I was young, before I had specialized in pelvic health, I thought, you know, prolapse only happened if you were really old, and it was always like a grade 4, which meant the organ was actually fully external. But actually, we know from the literature and the research that a lot of women post baby will have pelvic organ prolapse, and they're actually thinking of redefining it, that some degree of prolapse should almost be considered within the spectrum of normal post childbirth. You know, I think it's Peter Metz has done lots of research on that, and he's kind of saying, like, when do we really call it prolapse? If it's a grade 1, a small amount of descent, do we actually say, you know, that's almost within to be expected to some extent? So I think sort of not being scared if you have any of those symptoms is really important, not panicking and thinking, oh, prolapse, because I think a lot of people do, they kind of spiral and go into a bit of a naturally, because it can sound quite scary. But I think not being scared, realizing how common it is, and also that we can improve these things, just like we can improve all of these symptoms, and we can improve symptoms of prolapse. And they do even think there can be some degree of sort of improvement in where that sits within, you know, you can have prolapse move up a little bit, as well as the tissues sort of repair and heal and improve and strengthen, and tone improves. So there's a lot that can be done. So I think don't panic about prolapse. If you think you have it, or if you've been diagnosed with it, don't panic.
So it's probably worth mentioning here, because I know before I came into this realm, and when I associated prolapse, especially with the older woman, you know, it was always resolved via surgery.
Yes.
And that isn't the case for sort of on a milder end of a spectrum. And even it should always, non-surgical intervention should always be the first course of action. Am I right in saying that?
Oh, 100%, definitely. You should always try conservative first, and yeah, definitely go the non-surgical route before you consider any surgery. And there's so much good education out there on prolapse now for physios. There's so many people that can help. Do you know what I mean? It's yeah, definitely, Sam. It's not a surgical worst case scenario. There's a lot we can do to help. There's things like pessaries, which are great, that can provide support if you need them. There's so much that can be done. So definitely get in touch with like a women's health physio and go down that route first. But as I say, the main thing is not to panic if you have any of those symptoms, or you know, to sort of,
but not to ignore the symptoms as well.
Not to ignore them, to seek help and have them addressed. But yeah, not to kind of panic. And then other things that we see often as well post birth in the pelvic floor would be quite a lot of hypertonicity, so like basically the pelvic floor becoming very overactive, and that can lead to things like painful sex as well with your partner, if the pelvic floor is too held in a position of being switched on all the time, so we're not able to fully relax the pelvic floor. That's an issue as well. So they're probably the most common ones. I'm just trying to think if there's anything else I wanted to highlight, but yeah, that's kind of the most common things that I see post birth.
So
is there anything else? Yeah,
when people come to see you post C-section, what generally are the kind of things they would come to see you for?
So they come for just like, quite often people come for a mummy MOT, which is a general postnatal check. So they'll come, just a lot of people post C-section complain of feeling very weak, very, very weak. And I think obviously just with having had the incision across the abdominals, you can feel quite sort of weak from that. They also can be quite tense. So what I find post-section in particular is people tend to be quite guarded. They tend to hold themselves quite tight. This is anecdotal based on clinical experience, but they tend to hold themselves quite tense, and there can be quite a lot of bracing around the back and around the hips. All the muscles are a bit overactive, and I think it's natural. I think it's probably almost a subconscious protective mechanism of the scar and of the tummy. Often as well, I find the breast needs a lot of work. So when we have the baby and when we're pregnant, during pregnancy, obviously baby's taking up a lot of space around our abdominals, and it's very hard to truly use your diaphragm and breathe well to the base and the side of your lungs. And I think post-section, because obviously the tummy hurts, it can take a little bit longer to re-establish that connection to the breast. In the early days, if you've got your scar there, it's quite tender, so you're not really taking necessarily those nice big deep abdominal breaths in the first few days, and that can become a bit of a pattern and a habit. And then with all that tension, we need to almost just take a bit of time and relax everything and reconnect to the breath. And quite often the pelvic floor can become overactive if that pattern is present. I'm not saying it's present with every woman, but if it is, that overall guarded sort of protective pattern is there, then quite often the pelvic floor is overactive as well. So that's something we need to work on as well. And then obviously people want to know, they want to work on their scar, which obviously you're my go-to expert in the area. I do a little bit of scar work, but I quite often send people so yeah, I can do a bit. I do some myself, but if it's something I do send people to Sam and recommend as well, because I think it's so important to work on the adhesions and the fascia and get everything moving well again. And obviously with the scar, and that can have an effect on, you know, scar tissue and uterus and everything. So yeah, scar work is huge, and reconnecting to the breath is a big thing. And also, yeah, we come with leakage. So everything, we come with everything. Every person is different, and everyone comes with a different presentation clinically. So, but the guarding and the sort of tension thing is something that I see quite a lot in section specifically, post-section specifically.
Yeah, and it's funny because I guess when we think, or when people think about themselves post birth, whether it's vaginal or C-section, they often, you know, remark, I feel weak. My abdominals feel really weak, and yet when I put my hands on them, actually I feel a lot of tension.
Yeah,
So there's this kind of I can't think of the right word now to describe it, but you've got like
it's like a disconnect, isn't it? Like
yes,
they're feeling something, like they're feeling weak, and then the body's actually like over guarding and bracing. It's like a disconnect. Is that the right word? That's what. Yeah,
it's a very funny juxtaposition of what they sense is happening and actually what in reality is happening. But I guess it goes back to this thing that if you hold something in tension, it almost does create a weakness because it can't operate, it can't function correctly. So your abs are kind of totally switched on all the time. Some people are even almost pulling their tummies in, trying to suck everything in because they're so kind of guarded, but also really aware of the area. And that in itself is just not the natural state which our tissues should be held in, the way our body should be held in. And then it just can't do its job in that state. And I mean, I know I always use this with the bicep thing. If you want to strengthen your bicep, well, if your arm is like this all the time, you can't work the muscle.
Well. I love it. I think it's a good example. I use it when I talk about the pelvic floor. Like if you're holding it here and you're not relaxing it fully, then you can't expect it to. You need to take it through full range, here to here. You can't just hold it here in the middle tense all the time. And also you're not going to get strong. So if you're having leakage and your pelvic floor is weak, I'm stealing your thing, Pat, Sam. This is I'm going on with what you were saying. But basically, if it's here all the time and you're trying to strengthen it, it's not going to get stronger because it's already overactive. And it's basically saying the same thing, Jay. But as it's overactive all the time, it's not going to go much further. Whereas if you let it fully relax and you take it all the way through range, you can actually get more strength into the muscle. It's not as
so. How do we fully relax our pelvic floor? Because this is such an important question,
So I think using the opposite of the cueing, so the most effective cue to strengthen the pelvic floor is to close the anus and then lift, isn't it? So that's the one that they've shown in evidence that most people can identify with that. So like trying to stop yourself from passing wind or closing the anus. So close the anus and then lift. What's that?
I think this is so important because we so often say to people, just do your pelvic floor exercises. People don't know what to do. They're pulling up in all different places. And it really is as simple as saying, just pull in as if you're stopping a fart.
That is the best cue. That I think it's the one that most people identify with because we've all done it in a social situation where you don't want to pass wind. Everyone's done it. And I love, you've heard Elaine Miller, right? When she does her chat on it, and she talks about, like, imagine you're on a date with the most handsome man and you don't want him to smell this terrible fart, basically. And she says it's like nuclear, it's toxic, and you're holding it in. And I love it. I love listening to her. She's so funny. She's a women's health physio, in case you don't know who she is. And you've probably shared her stuff, I'm sure, Sam. So I keep wanting to say Pam. I don't know why. I've got Pam in my head. Pam in the curly. I have no idea why. I have no idea why Pam is in my head. And I know I'm talking to you. This is what happens when you do interviews in the evening after a busy day. So basically Elaine does that story, and I just think it's a really funny one, and it sticks in your head, like, and everyone's done it. Everyone's tried to stop wind in a social situation. So it's so simple, and I think it gets so confusing because everyone uses different cues. There's all sorts of mad cues out there for pelvic floor exercises, so it's just trying to find something functional. So stopping wind, closing the anus, stop wind, and lift. What I find quite helpful when we're trying to cue relaxation, it's quite good if someone's lying on their back, because you can use the opposite. So you can say, like, let everything sink down and feel as though your anus is opening. I don't know if that would work for you, but people like it and it does work. So if you're lying on your back and you're thinking about closing and lifting, you then want to think about let everything open and sink down. So it's just the opposite, but you want to think as if your anus is going down towards the bed. So sometimes I cue it in lying because it's quite nice. The other thing I think is really helpful to make sure you're relaxing is to actually put your hands on your cranium. Okay, so this is something we always encourage people to do as women's health physios. Is ideally everyone should look at their vulva before they have a baby and see what it looks like, because it will change post childbirth, and that's normal. And what we what we know is, and even if you have, okay, if you have a section, maybe not to extent, but there will be, there can be changes through pregnancy, there will be changes in the way things look with the hormonal changes, and then at menopause there will be changes to the vulva as well. So it is good to know what the tissues look like, what everything looks like down there. And the perineum is the area, is the area between the anus and the vagina. So like basically you put your hand down here, right? And it's like where you want to feel that body. It's a body of kind of muscle, and usually it lifts when you do your pelvic floor exercise, and then when you relax you should actually feel that tissue sink down. I wish I had a diagram now. I should have brought a diagram.
We should have a pelvis, shouldn't we?
Yeah, I should have had a pelvis. So basically it's that, but it's quite a thick muscular area, and if you just feel at the back of your vagina but not as far back as your anus, you will feel it. And I actually get people to palpate their own sort of genital area, because it really helps, and you want to feel that sinking down. And if I'm cueing it in like a Pilates class where it's not appropriate for everyone to start, I mean they can if they want, but if they don't feel, most people don't feel comfortable to do that, sometimes using a gym ball. So if you've got a breathing ball or even just a normal chair, that can give you a bit of feedback. So if you do your pelvic floor exercise on a chair, it can be a normal dining room chair, it doesn't have to be a gym ball, and you lift everything up, you should feel like everything draws closer, and you should feel things actually lifting slightly. And then when you fully relax, you should feel sort of everything in that area sinking down a little bit. And the gym ball is quite nice because you get that sinking sensation. But the simplest, so that, I don't know if I'm confusing it now by giving all these ideas, but another thing to think about then is between each lift, and close the anus and lift, relax, and then count to 5, and then lift again. So fully relax between contractions, because I think people kind of go, right, I've got to do 10 of 10 Kegels and hold them for 10, and they go lift 1 2 count to 10, then they relax slightly, then they go lift. So like going back to their bicep, they're here, they count to 10, this is their maximum hold, they go here and back, here and back, here and back. They kind of have a second between each one, and they're kegeling like mad, but they're not going relax, breathe, and then go again. You need to get that gap between each contraction to lift it. And even when you're doing your fast twitch, so if you're doing your Kegels, you're doing your slow, which is your long hold, and then your fast, which is your fast twitch fibers, your on and off, where you just on, off, on, off. When you're doing, I've heard, this is a horrible analogy, think of your anus winking on and off, right? It's horrible, but it does kind of work. But that's,
and keep breathing as well.
Keep breathing. And when you're doing on and off, so I think when you're doing the on and off, you still want to kind of go on, off, 1 2, on, off, 1 2. Even when you're doing the fast ones, have that 1 2 pause, then on, off again, 1 2, on, off. So it's not like a continuous on, off, on, off, on, off, because again, you can fatigue and you can end up holding tension in the pelvic floor. So that's some tips to try and help you to totally relax the pelvic floor. Another tip would be lots of kind of like happy baby yoga poses, where you take the legs up and open them wide, or having the legs up the wall at the end of the day for 10 minutes is such a restorative thing to do. Helps with lymph, helps with blood sort of circulation, but it also takes the weight off the pelvic floor. So if you've been on your feet all day, if you've got a job where you're on your feet all day, or if you're just busy running around after your toddlers and children, lying on your bed and sticking your feet up the wall for 10 minutes, doing a bit of deep breathing and just totally switching off is really nice for the pelvic floor as well. It's a really nice way to just relax. Yeah, it's lovely. It's lovely. I do it sometimes. My husband looks at me as if I'm not her. He's like, "What are you doing?" I'm like, "I'm chilling." Okay, just ignore her. But, yeah.
So can I ask you one last question, Kat?
Yeah, of course.
Why should people come and see a women's health physio after they've given birth?
Okay, so ideally everyone would do it. Like in France, they have it as part of their healthcare, and it's the ideal sort of, it means that so I trained in the mummy MOT, which is a sort of standardized postnatal check, and it means if you go to see someone who's trained in the mummy MOT, you know that they've been trained to like a good standard. And the women who actually made that format, made that sort of, basically, obviously it is a framework and each person's treated as an individual, but she made the framework to make sure everyone was of a standard. Everyone knew how to assess fully and comprehensively postnatally. And she actually trained in France. She spent a lot of time in France. So that's where she thought, we don't have this in the UK, it's crazy. So she brought that concept and tried to incorporate it into this postnatal check, which I think is fab. So it's really important because it puts you at ease, number one, and it it lets you realize that these things, I think I'm trying to think how to explain this. So after a baby, we basically put up with a lot of crap, don't we? We go through pregnancy, we go through childbirth. Everyone's like, oh, look, you've got a lovely, healthy baby. It doesn't matter about anything else. So that's the perception from society. Like people will say, oh, well, as long as you and baby are healthy. And that can kind of dismiss the mother's full experience of whatever's happened during that birthing process, and whatever issues they may be left with postnatally, like whether it's leakage, whether it's prolapse, whether it's a cesarean scar is not healing well, or it's giving them some issues. And I think the mummy MOT is just like, or any postnatal good physio, women's health physio doing a check, it's space for you to come and check in, see where you're at, check what's going on with the pelvic floor. We do an internal, we check the pelvic floor, make sure you're doing those Kegels properly. So even if you've got no pelvic floor issues, it's still good to get a check to see that you're still, you might have a bit of weakness. It's not presenting as urinary incontinence, but maybe you are a bit weak there, and you wouldn't know that without that check. So come for the check so we can see, are the muscles strong enough? Are they working well in coordination? Are you fully switching them off? And if you're doing all those things, then that gives you like, okay, that's good. And it means that going forward into the future, you know that you're able to continue doing that. And so I think space for mum, check in and just see if there's any issues. Also, we can look at tummy if there's any issues with tummy gap postnatally and give you advice. And the rehab is tailored to you as well. So whatever you've been through, whatever problems you may find or problems you're experiencing, you get tailored, personalized treatment from that as well. So I think it's just, yeah, take some time and look after yourself, because in that postnatal period, it's just so important, isn't it, to look after yourself as well. And future-proof your pelvic floor. Like get the right advice now. Yeah.
I think absolutely. I almost liken it, you know, when you join a new gym, you never, or rarely, if it's a decent gym, you don't just go and start using the equipment.
Yeah.
You get someone who does an induction, and they do a full health check, and then they prescribe you a program. So it's exactly the same with the pelvic floor. How do you know what you need to focus on if you don't know the current state of play?
Exactly.
And you know, and I think that, you know, you obviously spoke about hypertonicity. The pelvic floor can become too tight. Well, if we just kind of bash it with more Kegels blindly, you know,
exactly.
we're potentially perpetuating. So we need to know, where's our starting place. What do we need to do to
totally yeah, you're so right, Sam, because I think that's the point to make as well, like Kegels aren't appropriate for everyone. So although ideally, yeah, if you're doing like 10 once a day and it feels fine and you've not got any issue, that's fine. It's a good preventative thing to do. However, if you start doing Kegels, or you're doing Kegels thinking it's preventative but it's actually causing you discomfort, or you're doing them because you've got leakage and then the leakage isn't improving, then yeah, Kegels might not be for you. So I have people come in and they're always very surprised that the pelvic floor can be hypertonic, that it can be too tight. They always think, they're always like, that's a thing. No one, you know, that's not really sort of common knowledge. So then when someone is like that, sometimes I'll say, right, we need to just stop Kegling completely for a while, and we're working on other things. We're working on how to relax, or we're working on more global muscle control, like using glutes and rotators and other things. So it's, yeah, Kegels are, that's an important point to make, that Kegels are not for everyone. If you're doing them and it doesn't feel right, or you're still having issues, stop and get some help. Don't ignore it.
Yeah. So I am going to quickly check to see if there's any questions.
Okay.
1 moment. In fact, would it be easier? Trying to think the best way to do this.
And I think I ended up looking down at my phone like the other week when we were chatting.
No, we've got no questions just now.
Okay. Perfect.
So what we would do is there anything else you wanted to add?
I think we've probably covered all of it. Is there anything that you think is important that I haven't touched on post-section or pelvic floor in general, Sam, from your experiences as well? Is there anything that, you know,
I think the only thing we could potentially just quickly add in, because I am aware of the time, is just the effect of scar tissue on things like pelvic organ prolapse or pelvic health in general. I don't know if you want to add something.
I mean, You feel free to talk on that because that's your speciality is scar tissue. So I'm sure you will explain that better than I will. So do you want to add a little bit? Do you want to do that rather than me? Because I know you talk so eloquently about scars and adhesions and how they work. And I think you do it better than me. That's your, yeah.
Well, I think, you know, quite often when someone comes into me, whether they've delivered vaginally or via sorry, no, let me take that back. When somebody comes into me who has delivered via C-section and they may feel that things don't feel quite right with the pelvic floor, there is this link between, if we have tension which is being created by a scar, then it almost creates an imbalance in the way that the pelvic floor can work. So it can kind of knock out the coordination of the muscles. And if we can release that tension a bit, then that can release out the tension within the pelvic, say, cavity. So, you know, the structures within the pelvis. And sometimes, you know, that can be part of a management strategy for things like prolapse or urinary issues. I find it quite hard to say that. Would you say that kind of?
Yeah, no, that would definitely link with my experience as well, because I do think it kind of comes back to that whole guarding thing we were talking about. I think when the scar is a bit stuck or there's adhesions, that perpetuates that tension in the pelvic floor, that perpetuates that overall tension all around that area. So I think, yeah, the adhesions, once they're freed up and once the scar is more mobile, everything moves better, doesn't it? Because when you think of the core, you think of the cab, you think of it like this. It's Julie Weeb, isn't it? One of the she's a very good women's health physio. She talks about the canister. So the abdominal wall and the muscles and the abdominals are part of the canister. It's not just, your core is not just like, oh, it's a two-dimensional thing, and it's a three-dimensional thing. Your back, the muscles at the back, the tummy, the muscles at the tummy, the pelvic floor and the diaphragm. So the abdominal wall is very much part of that canister. So if there's an issue in one part of that, it has an effect on all the other parts. So yeah, I think what you said makes perfect sense.
Yeah. I think it's just, you know, and going to women's health physio can help with that whole treatment, with that sort of holistic approach of helping your pelvic health.
Definitely, 100%. And I always ask people when they come in, like, women probably get taken aback by me if someone comes in for MSK. I'm like, and how did you deliver? Did you have cesarean? And then I'm like, did you any issues with constipation? Any issues with, you know, I'm asking all these questions, and like, but I can't help it because I know that there can be some very simple tweaks we can make to pelvic things, like even just changing the way you position yourself in the toilet, things that can help. So someone comes with just a straightforward back pain, I'm still going to ask about pelvic health because it's linked to everything. You know, it's the straightforward back pain might be caused by their constipation. You know, once you start questioning, you realize there's a lot more going on. So yeah, definitely.
I think as society, we totally underestimate constipation. You know.
we do 100%. So yeah, I think that holistic approach is so important, and that is what we would do as women's health physios, is we look at the whole picture, the whole body. So yeah. So it was great.
Fantastic. Well, Kat, it's been absolutely brilliant having you on today to chat. So thank you very much for your wisdom and for sharing with us your expertise. And I look forward to chatting again soon.
Yeah, no, definitely. And if anyone has questions, do put them in the comments because I can get back to them later. If there, you know, someone watches this later on and then they think, oh, I wish I was live and I could have asked this or that, just either ask them questions or feel free to direct message me or ask via Sam if you're more comfortable to send a message to them. You know, just whatever way, I'm happy to answer any questions that people have, whether they're sharing them publicly or whether they'd rather ask them privately. That's absolutely fine as well. So do get in touch if there's anything.
And Kat, tell us where you can be found on Facebook and website.
Okay, is it okay if I post them? So it's basically cmphysiotherapy.co.uk. I think if you type that in, it'll bring you to the website. And then it's Catriona Monkhouse Physiotherapy and Pilates on Facebook. But I will later on post them into the comments below the video. I'll probably
Yeah,
Yeah,
Facebook
it is
page.
actually.
Yeah.
I know. I don't. Yeah, I don't know if I should change my names up. It's like it's a bit take out the amplitude. Maybe we'll see. We'll see. It's a bit long. So I'll post it into the comments. And yeah, just let me know if there's anything I can help with or any questions. And if you're not local as well, it's important to say I have like access to a directory of women's health physios and the community practitioners, and I'm also in like women's health Facebook groups and stuff. So if you're somewhere else and you're watching this from elsewhere, I can definitely find you a recommendation for someone local. So don't think, oh, I'm not near her, I don't know where to go. Ask and I can help you find someone relevant who can help you in your area. It doesn't, it doesn't need to be me. Just see a women's health physio if you have any of these problems that we've spoken about. All right.
Fantastic. Thank you so much, Kat.
No problem. It's lovely to chat to you.
Take care.
Thanks.